Thank you so much for kind introduction. I thank the organizers for giving me the opportunity to share my experience. I have tried to keep it as clinical as possible. Uh, Most of us doctors, when a patient complains of back pain, we first think of radiation, we look at red flags, and we do the MRI depending on the severity of symptoms, and then maybe give medication, exercise, block, and if worse, then surgery. Uh, no sciatic pain, then rheumatologists will think of inflammatory component, maybe vertebral fractures, osteoporosis, sometimes condensation coccydynia, facet joints, hip pathology, OA and AVN, and finally we'll diagnose mechanical back pain and refer to our physiotherapy colleagues. So, when I am supposed to talk on missed causes, what is left for me to talk is the systemic causes. So that means some intra-abdominal pathologies, rare malignancy, tumors, rare infections, pelvic fractures, myositis, and metabolic bone disease. However, all of you in this audience, I think, can diagnose this very well. We have lot of investigations for them. So then what is left for me to talk today? So I come back to mechanical back pain. If you look at all these causes, whatever we have talked, contribute not more than 20% of back pains. So remaining 70–80% is non-specific and we don't know what is happening. For example, look at degenerative pain. We all have osteophytes, disc degeneration and facet joints, more than 50 any X-ray you do, but not necessarily that will cause pain. And lumbar strain and sprain 70%, it is so non-specific. So let's look at the statistics of back pain in US. And if you look at, it is the most common symptom for seeing a physician in US. Up to 80% will have back pain at some point of time in their life, and acute will settle in 2 to 4 weeks. And about more than up to half will recur at the end of 1 year. 1/4 will have chronic low back pain. Risk factors are really common: obesity, smoking, sports, trauma, sedentary lifestyle. I think we all have something or the other. It is the third most common cause of disability after 45 years. It increases by 5% every 5 years. There is no mortality, but compensation costs in US are huge. And the expenses increase the moment we start doing MRI, procedures, surgeries. And mind you, without any significant improvement in patient outcomes or disability rates. And why does this happen? Because the complexity of the biomechanics of the spine makes it difficult to identify specific anatomic lesion. So the diagnosis is possible only in 20%. That means 60% we are missing here itself. So let me explain to you by example. Most of you in this audience know me, so you will know I am presenting myself. It began in 1992 with low back pain radiating to both legs. Diagnosed as prolapsed intervertebral disc L45-alpha-S1. Mind you, there was no MRI at that time, so it was diagnosed on CT. I kept getting intermittent pain, and in 1998, I had sensory loss on the lateral side and could not climb step from the right side. It was L45 disc, but I am purposely not mentioning where the weakness was because I am going to come back to it later. I recovered with local steroid injection and conservative treatment. However, as long as I can remember, I have had gluteal pains and leg pains, and they never got better. I had intermittent episodes of acute back pain, which were diagnosed by physiotherapists as sacral torsion, ligamental sprains, QL, spasm, piriformis syndrome. In 2014, I had worsening of back pain with neuropathic pains and walking limited to 500 steps. Underwent lumbar decompression surgery at L45-alpha-S1. There was some listhesis and a lot of epidural fibrosis on the MRI. Recovered with significant rehabilitation. However, the chronic problems remained. 2019, there was worsening of gluteal pain with radiation in the lateral part and the front of the hip with locking of the hip. Additional L3-4 disc, but there was no need for surgery at that time, so partial relief with nerve root injections. In 2021, in the peak of pandemic, I had severe pain, and you can see the L3-4 disc, how badly the canal, spinal canal was compressed. And there was a lot of disc edema and hypertrophy of the facets and edema. I recovered, the spinal cord expanded very well, but clinically I actually deteriorated and could not even walk 50 steps. So again, there was a lot of inflammation on the spine, general inflammation, which recovered gradually, did lot of rehabilitation. Again, the chronic symptoms remained. With lot of rehabilitation, I can now walk up to 2 kilometers, can do swimming, yoga exercises. However, just to summarize, it's a long-standing PID with multiple acute on chronic episode, neurodeficit, 2 decompression surgeries at different level, and epidural fibrosis. The problems which still remain are gluteal pains, sitting, standing, and walking is very limited, in acute on chronic spasms in QL and latissimus, and leg pains and belt I have to wear all the time, which you have seen. So there were a lot of further diagnosis on rehabilitation, gluteal weakness, no further improvement in the muscle mass or strength, gluteal tendinopathy, SI upslip, pelvic list, fascia issues, post-interventional fibrosis, thoracic fulcrum due to fixed spine, cervical and thoracic muscle deconditioning. And I am going to go through all these. Now, I want to spend little time on this slide, because all of these diagnoses, except post-interventional fibrosis, was done only by physiotherapists. Nothing except gluteal tendinopathy was seen on any of the investigations like USG, MRI, and nerve conduction studies. No doctor, like neurosurgeons, spine surgeons, physicians, nobody diagnosed gluteal weakness despite telling them repeatedly, or accepted any of these diagnoses ever. So let me see if I can show you what is there clinically and why are we missing it. This actually was done to demonstrate that what exercises are good for back while doing yoga. So I want you to observe. Unfortunately, there is no time to discuss what I am showing you, so I am just going to go ahead. See this? And this is when I am not in pain and ready to do all the exercises. And see this. So a year ago, when I took a second opinion, I was diagnosed with SI malalignment. There are various types, and I have mentioned about sacral torsion. So what happens in sacral torsion is sacrum is fixed and vertebral column rotates around that. It is easily corrected by manipulation. The second one is a moderate level, which is an in-flare. It's the anterior rotation of hip, and out-flare is a posterior rotation of hip on the sacrum. And what I had was SI upsleep. SI downsleep is extremely rare. So what happens in the upsleep is the ilium shifts little upwards, as you can see. And why does this happen? It's because the gluteal muscles are weak and QL is overworked and it is in spasm. So, and this is not seen on MRI. So I have shown you the pelvic level. I have shown you the QL spasm. And there is a leg discrepancy which was there last year. And the pain got immediately, some part of the pain got immediately corrected when they did manipulation, and I could do exercise a bit. And mind you, 3-4 times it recurred, because obviously the muscle imbalance will take some time to get better. So till then, when I did something extra, I had this again. So this is me just a month ago. It was done for the presentation. Can you see? I again want to observe you and see what I am showing you. This is the common test which we have mugged you from MBBS days, and I want you to see what this test is. Any of you can tell me. Can you see the lateral list? This is how I stand naturally. Despite correcting the upsleep, this is what I still have. What is this? Trendelenburg's, and it is positive. The pelvis is not lifting up on the left side, and see, it was up and it has gone down when I just lift the leg. And this is so easy to do. I just have to lift my leg, that's it. But nobody ever did it. On the right side, it is difficult to comment because it is already low, but definitely pelvis still doesn't shift up. So this is Trendelenburg's. I'm good, isn't it? Look at this. This is how I stand if I don't correct myself, and this is after contracting gluteal medius. And I can't stand like that for a long time. I'm so good. Look at that. This is a chronic QL spasm when I'm not in pain. So quadratus lumborum is the deepest muscle in the pelvis. It extends from pelvis to last rib, as you can see. It contracts while sitting, walking, standing, and susceptible to pain. Mostly it is because of overuse, and sometimes it can be because of the weakness and tension. You can see the different QL trigger points. So typically what happens is weakness in the gluteal muscle is biggest contributor to QL, tight QL. Additionally, whenever you crouch, there is the QL has to come in, has to overwork to prevent you from falling forwards. And whenever you lift your leg, because the gluteal is weak, in the frontal pain, it's the gluteus medius which has to lift the leg. So if gluteus medius doesn't work, the QL comes into play. And similarly, in extension or arching, when gluteal maximus is not working, that's when the QL comes into play again. So weak hip musculature, overworked QL, tightness from daily habits, because whatever you do, you are using the muscles, rapidly moving into extension or side bending or worse both is a perfect recipe for acute on chronic spasm. So let's look at the further. What typically happens with the gluteal muscles and weak abdominal musculature like transversus and all the other abdominals, and these muscles are inhibited, and the superficial muscle in the cross connection like tight iliopsoas and tensor fasciae lata become tight, and your erector spinae, QL, latissimus, multifidus, all these muscles become tight, and this causes anterior pelvic tilt, and your flexors are tight, and a lot of time gluteal muscles your hamstring compensates and they become tight, so causing pain everywhere. There are two types. Both have thoracic hyperkyphosis, one with lumbar hyperlordosis and other with lumbar hypolordosis. Coming to fascia, we all know it's a fibrous tissue. I'm purposely reading it. It surrounds, supports, suspends, protects, connects, and divides. It gives nourishment. It balances between tension and compression. Mechanotransduction is what happens is it converts physical forces and transmits into intracellular biochemical forces, altering the expression of fibroblast. And repeated fibroblast strain ultimately causes a lot of changes in and influences regular day-to-day functions of the force transmission and gliding, and causes pain, proprioceptive issues, and atrophy and weakness. These are the concept of fascia lines by Tom Myers. It is a great way to understand how body functions and how treatment can be optimized, increasing mobility and functionality. The basic hypothesis is that no matter what muscles do individually, they also affect tissues throughout body through fascia connections. And there are 12 lines described, and see how they will mimic nerve root pains. This is an infraspinatus, the green one, and see it can mimic the nerve root pain. And similarly, your glutes and your adductors can mimic the pain. Again, this is a big topic by itself, but I will mention only the piriformis syndrome because it is the commonest where sciatic nerve passes through it. And most of the people will have it when you examine. However, rarely other nerves can get involved, and it's a cause of extraspinal sciatica in deep gluteal space. When somebody says failed back syndrome, and this has actually happened to me, you actually feel like a death sentence because you don't, it's like saying that you don't know what is cause of pain and nothing can be done about it. So, and it can be of any characteristic. I'm not going to go into detail, but these are all the causes. So practically it means anything can be there and nobody knows what is there. But I just want to mention that epidural fibrosis, which I mentioned, can happen in up to 20 to 35% of the patients. So it can be early, subacute and chronic, and there are a lot of inflammatory markers. Just a last thing, that I had epidural artery pseudoaneurysm and bled like mad during second surgery, again not seen on the MRI. So glute status is very important along with the core muscles, and we all need to examine that. Missed causes are common, and we need to learn to recognize with holistic approach rather than looking at individual joint and muscles. And for chronic back pain, we need to learn evaluation from our physiotherapy colleagues and need to look at muscle deconditioning, improper posture, body mechanics, overuse, and help the patient. So if each of you can make somebody relief of pain, I think my presentation and pain will be worth it. Thank you.